Hello, in this episode we'll try to make sense of a challenging topic, the respiratory failure. First challenging question is true or false? Normal oxygen saturation rules out respiratory failure. The answer is false. Why? Please remember SpO2 is a surrogate of oxygen saturation, SaO2. And we measure this SaO2 through its surrogate to function as a surrogate of PaO2 because measurement of PaO2 requires invasive arterial blood gas measurement. However, the limitation is due to the fact that SaO2, through its shadow SpO2, is not a good reflection of PaO2 or the arterial pressure of oxygen for critically ill patients. And the reason is SaO2 is a good representative of PaO2 only when we have normal levels of PaO2. But there is more to this. The absolute cutoff values for either SpO2 or PaO2 are not very well established in a universal manner. And the interpretation of the values require a dynamic approach. And I give you two examples for this. One is we need to evaluate changes of SpO2 in terms of patient baseline. Even though most references say an SpO2 greater than 90 to 95% is considered normal, if the patient's baseline is 99% and now you see the patient has 95% and some shortness of breath, that SpO2 of 95% is considered abnormal for that patient. On the other side, for COPD patients, they are adapted to function properly in a SpO2 range of 88 to 92%. So for a COPD patient, we are okay with 90% SpO2 if the patient otherwise is asymptomatic and functional. Now, for all practical purposes, just remember the most agreed reference range for SaO2 is 95% at rest for minimum normal values. And also, exercise-induced desaturation is considered clinically significant if it causes more than 5% drop of SaO2, 5 or more. I would like us also to correlate the values of PaO2 to their corresponding SaO2. I would like us to remember the normal range of PaO2 is usually considered 70 to 105 millimeter mercury, and this value corresponds to an arterial saturation of more than 90%. Also, associate the millimeter mercury value for PaO2 of 45 to 65 to an SaO2 value of 85 to 95%. You can simply remember the formula that I've made for us: 50, 60, 70 corresponding to 80, 90, and 100, or 95 instead of 100. That is 40, 50, 60 millimeter mercury corresponds to 80, 90, and 95% SaO2. Now, we have a next challenging question, and that is, how do we differentiate the two major types of respiratory failure? And the answer is not by presence or absence of hypoxia or hypoxemia, but by presence or absence of hypercapnia. Why is it so? First reason is many causes of hypoxic respiratory failure could be purely hypoxic. However, many causes of hypercapnic respiratory failure are mixed hypercapnic and hypoxic. Put it simple, hypercapnia is usually associated with hypoxia, and another way to describe it is hypercapnic failure is usually a mixed hypoxic hypercapnic failure. Third question, what means or tools are available to us to differentiate hypoxic versus hypercapnic respiratory failure? Well, we need to pay attention to the overall clinical picture as the risk factors differ between hypoxic and hypercapnic type, but also we need to be able to apply indices of oxygenation versus indices of ventilation when we initiate the treatment. This is the second method. And the third method is application of the formulas dealing with differentiation of several types of hypoxic versus hypercapnic failure. Again, I repeat that you need to know the clinical picture and risk factors. You need to know the treatment response based on the ventilation versus oxygenation indices. And the third is you need to really know the formulas that discuss oxygenation versus ventilation. We will discuss the formulas alongside the clinical pictures and risk factors. So let us now just simplify the oxygenation and ventilation indices. These are the indices that when we initiate oxygen supplementation, we will evaluate either in our invasive or non-invasive means of oxygen supplementation to see how the patient responds and what variables require modification. So what are the indices of oxygenation? They include FiO2 and PEEP. Again, you have initiated your ventilatory or oxygenation support and you notice that the patient has increased FiO2 or increased PEEP requirement. What does that mean? That means the patient has hypoxic respiratory failure. Now, what are the indices of ventilation? The indices of ventilation are tidal volume and respiratory rate, because the formula of alveolar ventilation is simply tidal volume times respiratory rate. If the patient has increased requirement of these variables, it means the patient has hypercapnic respiratory failure. This will come very handy when in the next episode we are going to discuss the management of respiratory failure and different settings of mechanical ventilation. But now let us turn our attention to the bulk of today's discussion, that is differential diagnosis of different subtypes of respiratory failure based on the clinical picture and the application of formulas of oxygenation and ventilation. Now, I'm trying my best to make sense of these formulas by conceptually explaining them so that we don't necessarily go through memorization. But we need to do some minimal memorization here. There are just 3 or 4 formulas. They will come really handy, not on your assessment of obstructive versus restrictive lung disease, but on your assessment of respiratory failure and pathogenesis understanding and choice of treatment. Now, we are just dealing with 3 formulas in hypoxic failure. That is Fick principle of gas diffusion, the other is alveolar arterial gradient, and the other is oxygen delivery formula. Let's start our cases. Case 1, you have a patient with dyspnea and you want to see if you need to rule out respiratory failure in that patient. What's the next step in your workup? As always in clinical medicine, we begin with physical exam and history. No matter how simplistic it may sound, in just a matter of, let's say, 3 months rounds in both ER and hospital, just last year I remember, I managed to identify 3 to 5 cases of impending respiratory failure requiring immediate mechanical ventilation by paying attention to just a couple factors in physical exam. I didn't even know their oxygen saturation. One of the factors was, of course, the findings associated with respiratory distress, including use of accessory muscle, monosyllabic speech, or altered mental status, and the retractions. However, you may not believe me that perhaps your most important assessment is respiratory rate. Please build a habit of measuring patients' respiratory rate in a matter of 15 to 20 seconds and see if the patient is breathing faster than the normal range for the age. For adults, remember 16 to 18 breaths per minute is the maximum. And if the patient is breathing faster than this, it means the patient is risking respiratory muscle fatigue and may immediately fall into respiratory arrest. Another thing that I would like us to always keep an eye on is any degree of altered mental status in a patient with labored breathing, as a very important indication of impending or present respiratory failure. Okay, after you paid attention to these variables, what is the very first test you need to order? We still need to order the non-invasive SpO2, despite all the negative things I mentioned about it. And if the patient is desaturating or if the levels are considerably lower than 95%, we need to move on with the next step management. So, in a patient with any of the previous findings or a patient who is desaturating, what's the very next step in the assessment? Ordering ABG, because that is the test that helps us know exact levels of arterial pressure of oxygen. Again, I cannot emphasize enough on this fact that SpO2, which is a surrogate or a shadow of SaO2, are not reliable in patients with critical condition or low PaO2. and we need to directly measure PaO2 through the invasive arterial blood gas analysis. Now, if PaO2 is less than 70 or 65 to 70%, you are dealing with hypoxia. Now, even though many of your review references mentioned the next step is differentiating between several causes of hypoxemic failure, there is some confusion about the difference between the hypoxemia and hypoxia. So our first step in the management and workup is actually to figure out if we are dealing with hypoxia or hypoxemia. And why is it important? It's because you may have a hypoxic respiratory failure who is not hypoxemic. Or better to say, you may have a hypoxic condition that's not hypoxemic respiratory failure. Now, what's the difference between the concept of hypoxia versus hypoxemia? While hypoxemia is just a lab measurement, which means PaO2 less than 70% or reduced PaO2, hypoxia means impaired tissue oxygenation, which could be due to hypoxemia or could be due to non-hypoxemic causes of hypoxia. What formula helps us differentiate between hypoxemic hypoxia and non-hypoxemic hypoxia? Well, PaO2 itself tells us if we are dealing with hypoxemia. However, if PaO2 is normal, we still need to rule out non-hypoxemic hypoxia. And as I mentioned, it is tissue oxygenation, so we need to apply the oxygen delivery formula. Remember, you may not be provided with the indices of oxygen delivery, but you may be provided with the clinical scenarios, or you may be provided with an alternative to oxygen delivery formula. What's the alternative for assessment of hypoxia? That is arteriovenous oxygen gradient. Let's briefly discuss the O2 content and O2 delivery formulas. Think of O2 delivery as a function of O2 content. It's worth it, however, to recall that cardiac output is not only stroke volume times heart rate, but it's also calculated based on O2 consumption and arteriovenous oxygen content. I would like us, however, to read this formula from right to left. And what I mean by that is that if we are dealing with a condition with increased oxygen content, we need to have increased cardiac output. On the other side, if the arterial oxygen content is high, the cardiac output does not need to go up, the cardiac output can go down. Commit this arteriovenous oxygen content to memory, as we are going to discuss its significance in a bit. But let's turn our attention to perhaps the most difficult formula of this episode, and that is O2 content. I want us to conceptually understand O2 content as oxygen capacity of hemoglobin times oxygen saturation plus dissolved oxygen content. Put it simple, total oxygen content is either the hemoglobin bond oxygen. Now, what is oxygen capacity of hemoglobin? It is simply defined as 1.34, and that simply means each gram of hemoglobin is able to carry 1.34 milliliter of oxygen if fully saturated. That is why in the oxygen content formula we need to consider oxygen saturation as well. Now, normal blood contains 15 grams of hemoglobin, right? So for 15 grams of hemoglobin times 1.34 milliliter of oxygen, we come up with the number of 20.1. This number, 20.1 milliliter of oxygen bound to fully saturated hemoglobin. However, if hemoglobin is not fully saturated based on our SpO2 or PaO2 measurements, we need to consider that saturation level in the formula. So this is the hemoglobin bond oxygen. Now, how do we calculate the dissolved oxygen? It's just to remember that every milliliter of blood would dissolve 3 times 10 to the power of minus 5 grams of oxygen per millimeter mercury partial pressure of oxygen. Now, given the fact that we usually measure blood in terms of deciliter, which is 100 milliliter, and we usually utilize 100 millimeter mercury as partial pressure of oxygen, we can simplify the dissolved oxygen content of the blood as 100 milliliter times 100 millimeter mercury times 3 times 10 to the power of minus 5, that equals 0.3 grams per deciliter dissolved oxygen of the blood. So at the end, oxygen content would be 20.1 plus 0.3, but one of them is the hemoglobin bond, so it is defined as milliliter per deciliter of blood, and the other is the purely dissolved oxygen and is defined as gram per deciliter. So we have 20.1 milliliter plus 0.3 gram per deciliter of blood as the total oxygen content. Now let me tell you what's the clinical relevance of this. What type of respiratory failure is possible in a patient with dyspnea and a hemoglobin of 9 gram per deciliter? Well, as you can see in the formula of O2 content, the O2 capacity of hemoglobin is reduced, so we multiply not 15 to 1.34, but we multiply 9 times 1.34. which gives us a value around 12 to 13 instead of 20.1 for the hemoglobin bond oxygen. Likewise, what do you expect to see as total oxygen content of the blood in a patient with polycythemia vera? Well, for the same reason as you can see here, because of increased oxygen capacity of hemoglobin, and that's because we have more than 15 gram per deciliter of hemoglobin, the total oxygen content of the blood is increased in polycythemia. Next question. What happens to the other component of oxygen content, that is oxygen saturation or dissolved oxygen? In anemia or polycythemia, these variables remain within normal range. They don't change. Next case. A burn patient has headache and confusion, but SpO2 is within normal range, or the reading is, for example, 94, 96, 97%. You are concerned with the patient, so you order ABG and you notice that PaO2 is also within the normal range of more than 70 millimeter mercury. So you are happy that the patient does not have any respiratory failure and decide to monitor the patient. 2 hours later, you are called to ER because the patient is having cardiac arrhythmia. By the time you arrive, the resuscitation efforts seem failing. What went wrong? 2 things. One is the clinical picture of a burn patient with headache or any degree of altered mental status hints in favor of carbon monoxide poisoning. However, both our first and second step workups, that is pulse oximetry and ABG, could be normal. Why is it so? First, because we mentioned at the beginning of this episode that SaO2 is not a reliable index of PaO2 for critical patients. Furthermore, in the specific case of carbon monoxide poisoning, pulse oximeter confuses carboxyhemoglobin as oxygenated hemoglobin and reports a normal oxyhemoglobin saturation. The second problem, which is even worse, is that PaO2 could be normal in your ABG report. And the reason is carbon monoxide can drop oxygen content without necessarily reducing partial pressure of oxygen. Why is it so? It's because the main index in our oxygen content formula that's manipulated by carbon monoxide is oxygen saturation of hemoglobin. And to properly measure that, we need co-oximetry, not simple pulse oximetry. Co-oximetry measures both oxyhemoglobin and carboxyhemoglobin. What should have been the treatment for this patient? 100% oxygen started immediately, preferably with nasal cannula or face mask. And then if the patient seemed to have severe CO poisoning in co-oximetry, that's indicated by increased carboxyhemoglobin percentage of more than 25, we need to use hyperbaric oxygen. What is the other challenge of these patients? Usually with airway inhalation of smoke during a burn, the possibility of airway edema and sudden respiratory arrest because of sudden complete obstruction of the airway. That simply means be on alert for the need for endotracheal intubation for these burn patients. So even though these formulas seem to be a bit painful to commit to memory, it could save lives. So please bear with me. In CO poisoning, what would be the oxygen content of the blood? Well, among the three factors, oxygen capacity of hemoglobin is not changed because the level of hemoglobin is not changed. Also, dissolved oxygen is not necessarily changed, but the oxygen saturation is dropped, and therefore oxygen content of the blood is low. Next case is a case of malignant hypertension, or alternatively, it could be also a burn case. In the case of malignant hypertension, the patient received an IV infusion to control blood pressure, and due to severity of blood pressure readings, the infusion went on for a long couple-hour period. Now the patient has altered mental status with labored breathing that smells like bitter almond. Again, not cherry, but almond. What is your next step for the management of this patient? Well, we need to immediately stop the nitroprusside antihypertensive. That's the only one that's related to cyanide poisoning. And other risk factors include burn patients, among other risk factors. The clue is bitter almond smell of the breath. What's the management? The management is sodium nitrate that induces methemoglobinemia, which is oxidization of hemoglobin. This oxidized hemoglobin goes and binds the cyanide and frees the cytochrome oxidase, cytochrome C, from the cyanide binding. Then we administer sodium thiosulfate to help our hemoglobins get rid of cyanide by producing thiocyanates. This is the traditional kit as cyanide antidote. The newer kits use vitamin B12, hydroxycobalamin, to convert cyanide to cyanocobalamin. So if you are asked what is the change in oxygen content in cyanide poisoning, remember, oxygen capacity of hemoglobin is not changed. There is no change in the hemoglobin concentration. There is also no change in hemoglobin saturation. That's the major difference with CO poisoning. And also there is no change in dissolved oxygen. And based on all of these, there is also no change in PaO2 or SpO2 measured by your pulse oximeter or ABG. The other challenge is the almond odor is not necessarily present or sensitive or specific. So how we are going to diagnose cyanide poisoning when we have these symptoms, which are themselves general? Here is why I mentioned we need to know an alternative formula to our oxygen delivery formula, and that is arteriovenous gradient of oxygen content. Remember, AV gradient of oxygen is reduced in cyanide poisoning. Why is it so? Remember, the function of cyanide poisoning, the mechanism is impaired electron transport chain and cytochrome oxidase dysfunction. Simply, tissue uptake of oxygen is impaired. Everything else is normal. And when tissue uptake is impaired, there is not enough oxygen that goes from the arteries to the tissue, and therefore oxygen remains in the venous circuit. By definition, an increased venous oxygen content of more than 90%, either on your VBG or any method that you measure the SvO2, venous saturation of oxygen, favors the diagnosis of cyanide poisoning. Finally, what type of respiratory failure is possible in heart failure? Again, returning to our oxygen delivery formula, but this time in the cardiac output part of it. You may be asked the same question about a patient with ventricular tachycardia. The stroke volume time heart rate is impaired. The cardiac output component of oxygen delivery is impaired in these cardiac pathologies. So just briefly what we've discussed so far, we have the non-hypoxemic causes of hypoxic respiratory failure. If it is due to low cardiac output, the typical example is congestive heart failure. If hemoglobin is changed, such as in CBC, we are dealing with anemia. In carbon monoxide poisoning, also in methemoglobinemia, we are dealing with low oxygen saturation. But if everything is normal except decreased arteriovenous oxygen gradient, we are dealing with cyanide poisoning. That being said, we have the second category of hypoxic respiratory failure, and that is the hypoxemic type hypoxia. That's the conditions in which PaO2 is dropped to values less than 70 millimeter mercury. Now we have a couple formulas here, including alveolar arterial gradient that incorporates PaO2, A capital for alveolar, as well as PiO2 and Fick's formula of gas diffusion. Remember, every single one of these have direct contribution in your differential diagnosis list and in your management. So the first question in this scenario is if you have a patient with sign or symptoms or SpO2 in favor of hypoxia and you ordered ABG and you figured out that PaO2 is also low. In other words, you are dealing with a hypoxemia. What is the very next step? We have to calculate alveolar arterial gradient of oxygen. Okay, so let's go back to our formula workshop and analyze the AA gradient and PaO2 formula. So we need to remember the PaO2, the partial pressure of oxygen in the alveoli, equals PiO2, pressure of inspired oxygen, minus PaCO2 by R. Why we need to do that? Because we need to calculate Pa capital of O2 to put it in our A minus A lowercase gradient. That capital A in our AA gradient is the Pa capital of oxygen. So let's first review what is PiO2. Well, that's the simple one. The PiO2 by definition is fraction of inspired oxygen minus the difference of atmospheric and water pressure. Now remember, the FiO2 is usually 21%. That's 21% of the air we breathe is oxygen. Atmospheric pressure is usually 760 and water pressure, the vapor pressure, is usually 50. So this is 21% of around 700 and the value is something around 150. So PiO2 is around 150. So that is what I've written. 150. How about PaCO2 divided by R? Well, PaCO2 correlates with CO2 production directly and inversely related to alveolar ventilation. And please do not commit to memory this. Just it is logical that the content of CO2 depends on CO2 production, right? And also the more we ventilate, we mentioned that ventilation is the index related to hypercapnia. So if we ventilate enough, we are exhaling CO2. Therefore, alveolar pressure of CO2 is inversely related to ventilation. I've put the formula of minute ventilation for you here, which is the difference between tidal volume and dead space times the respiratory rate. Please remember this formula. Why? Let's put it in a case. A patient who is having pulmonary embolism is breathing fast. That is an increased respiratory rate. That is, ventilation is increased, right? When alveolar ventilation is increased, it means the denominator of PaCO2 formula is increased, and therefore PaCO2 itself is going to be low. And that's why we say in pulmonary embolism we are dealing with hypoxic respiratory failure, not hypercapnic respiratory failure. So you may just be asked what type of respiratory failure is possible in this patient. Now, if you put the PaCO2 in this formula, you would see that it may be even associated with increased alveolar pressure of oxygen. So your question may be, why then we have possibility of hypoxemic respiratory failure if PaO2 is increased? Well, remember that it relates to our A minus A gradient. If A is increased, the A capital. If A capital is increased, we will have increased A capital minus A lowercase gradient. That is, alveolar arterial gradient is increased. And that means what? That means ventilation perfusion mismatch, especially in the case of pulmonary embolism. So you see, these formulas really matter, right? Just by increased respiratory rate, we had increased alveolar ventilation, and therefore we had decreased PaCO2, and therefore we had increased P alveolar of oxygen, and therefore we had increased alveolar arterial gradient, and therefore we say we are dealing with a mismatch. Like you know already, in the case of pulmonary embolism, one of the diagnostic approaches is ventilation perfusion scanning. Now, one little point about this little r that we have here in the formula of PaO2. What's this r? Remember, this is respiratory quotient. It's directly proportional to CO2 production and inversely proportional to oxygen consumption. In addition to that, you need to know R normally lies within 10 to 15. It's increased by protein and carbohydrate diet, and its value is decreased by fat diet. So let's practice this. If you are provided a patient who follows low carb and high fat like keto diet, they may ask you what you expect to see in the alveolo-arterial gradient of oxygen. Okay, fat reduces the R. If the R value here is reduced, PaCO2 divided by R is increased. If this value is increased, then PiO2 minus this value is decreased. Therefore, we say Pa capital of O2 is decreased, and therefore in a person who takes fat diet, A minus A gradient is decreased. So here is the real juice of differential diagnosis. We have a patient with hypoxemia. We calculate AA gradient. There are two possibilities. One is increased AA gradient, and the other is normal AA gradient. If AA gradient is increased, what are the differential diagnoses? We have two groups of conditions. One is limitations on diffusion versus the conditions associated with ventilation perfusion mismatch. What are the differential diagnoses of mismatch as the cause of increased AA gradient? Ventilation perfusion mismatch is either due to shunt or increased dead space. Clinical pictures apart, how do we differentiate these two conditions associated with ventilation perfusion mismatch? Please remember, as the rule, any condition associated with shunt is not responsive to 100% oxygen supplementation. On the other side, dead space, such as what we see in pulmonary embolism, is responsive to 100% oxygen. That is, the patient oxygen saturation or PaO2 improves. Is there any exception to these rules? Yes. If we are dealing with a massive pulmonary embolism, we are not only dealing with dead space, but it creates such a large dead space that would also not respond easily to oxygen supplementation. Now, among the shunt conditions, pneumonia still responds to 100% oxygen. Now, we mentioned pulmonary embolism is an example of dead space. What are the examples of shunt? Well, the famous example are the intracardiac right to left shunts, the so-called cyanotic congenital heart diseases. The other example is atelectasis, pneumonia, and obstructive lung disease. Also, please remember that the shunt conditions are initially associated with hypoxia, but later on, because of the respiratory muscle fatigue, we have buildup of CO2, and then we have mixed hypercapnic, hypoxic respiratory failure. Now, the second category of increased AA gradient in hypoxemia is conditions associated with diffusion limitation. To understand the differential of these conditions and also their management, we need to review our Fick formula of gas diffusion. I promise this is most likely the last formula we are going to discuss in this episode. Just remember, Fick's formula is memorized by the acronym ADAPT. A times D times delta P divided by T. So A is the surface area, D is the diffusion coefficient of the gas that does not change under normal circumstance. Delta P is alveolo-capillary gradient of gas, and T, of course, is the thickness of alveolo-capillary membrane. Now, our focus will be mainly on the thickness factor and surface area. What condition is associated with decreased surface area in the Fick formula? That is emphysema, associated with destruction of alveolar wall. What conditions are associated with increased thickness of diffusion membrane? Any condition with lung fibrosis or decreased lung compliance. So if you are given a case of pulmonary function test in a patient with dyspnea, and you are asked if you are dealing with perfusion limitation or diffusion limitation, as the underlying cause of hypoxemia. What's your answer? Well, because the thickness of diffusion membrane is impaired in patients with restrictive interstitial lung diseases, we are dealing with diffusion limitations. Now, what are the examples and categories? In this category, with increased thickness as a cause of increased AA gradient, we need to order a test to rule out the most severe or concerning cause, and that is ALI, acute lung injury or acute respiratory distress syndrome. What is that test or assessment? That is P to F ratio. This formula, P to F ratio, is very important because it tells us if there's any barriers from the air that's being inspired to reach the arterial capillaries. And so that barrier cannot be anything but increased thickness of the gas exchange membrane. If the ratio is less than 300, that means there is a diffusion barrier. Now, a diffusion barrier is either lung fibrosis and interstitial lung disease, or it's acute respiratory distress syndrome. If P to F ratio is mildly reduced, that is within the 200 to 300 range, we are dealing with non-ARDS causes such as interstitial lung disease. However, if P to F ratio is less than 200, we are dealing with acute lung injury, ARDS. And always remember, the index of severity in ARDS is what? Is a P to F ratio less than 100. Now, if you return to the Fick's formula for the last part of our discussion, you remember we talked about this delta P here. Do not confuse this delta P with alveolo-arterial gradient or AA gradient. This is alveolo-capillary gradient because we are dealing with the diffusion. We are dealing with a membrane. On one side of it, we have alveolar pressure of oxygen, and the other side, we have the pulmonary arterial capillary pressure of oxygen, equivalent of systemic venous pressure. Now, remember, at high altitude, this delta P is decreased, and because the delta P is a propelling force for diffusion, we will have decreased diffusion of the gas. Now, the question is, do we have increased A capital minus A lowercase gradient? And the answer is no, because in high altitude, both partial pressure of alveolar oxygen and partial pressure of arterial oxygen are reduced, and therefore A capital minus A lowercase is not reduced. In other words, in high altitude, even though diffusion is impaired, A minus A, the alveolar arterial gradient, is not increased. Please pay attention to this fact. The final example in which the alveolo-capillary gradient is manipulated in a way that gas equilibration does not happen. Remember, the purpose of diffusion is equilibration. So anything that impairs equilibration would also be considered an impairment of diffusion. The example is exercise for oxygen diffusion. Because the timing of diffusion is reduced to such a point that equilibration can never be achieved, we say exercise is an example of oxygen diffusion-limited gas exchange. While in normal condition, that flow is not that fast in the alveolar capillaries, we have enough time to reach the equilibration. Again, this is a concept of huge confusion in respiratory physiology when it comes to perfusion-limited versus diffusion-limited gas exchange, and now you got that. If you have any barriers to diffusion, if we are dealing with exercise that eradicates the possibility of equilibration, or if we are dealing with high altitude that we do not have, or we have reduced levels of delta P between alveolar capillary components, we have diffusion limitation. Final example of diffusion limitation, gas exchange happens all the times for carbon monoxide. Do you remember examples of perfusion-limited gas exchange? CO2, oxygen exchanged during the normal health, not during exercise, N2O, and congestive heart failure, exactly opposite of what happens in exercise. The gas equilibrates quickly in the entire length of capillary before the RBCs and blood are moved forward. That happens when the circulation is slow, as in congestive heart failure. Or equilibration happens very quickly, as in the case of CO2. Because of very high diffusion coefficient of CO2, equilibration happens very quickly. So when we have a perfusion-limited gas exchange, such as in congestive heart failure, oxygen under normal circumstance, or CO2 and N2O, these conditions mean improved gas exchange would happen only if we improve the perfusion. That's the cardiac output and the speed of blood flow in the pulmonary capillary vessels. This brings us to the next scenario in the hypoxemic respiratory failure, and that's when AA gradient is not increased. By now, I expect you to give couple differential diagnoses. What are the common differentials? When we have high altitude breathing, both alveolar and arterial pressures of oxygen are reduced, and therefore A minus A is not changed, is not increased. Another example is when we have impaired ventilation, which is important differential of hypoxemic, hypercapnic, or mixed respiratory failure. The examples of impaired ventilation are CNS disorders and obesity or chest wall disorders. Right here, it's a good moment to bridge to the differential diagnosis of restrictive lung disease. If you have a restrictive pattern in your spirometry, but diffusion capacity of the lung for carbon monoxide is reported to be normal, what do you expect to be the AA gradient? Okay, there are two types of restrictive lung disease. One type is interstitial and the other is non-interstitial lung disease. And the way we differentiate them, if you review our introductory episode to restrictive lung disease and differentiation of restrictive versus obstructive, is that in the interstitial type, the LCO is decreased. Remember, similar to P to F ratio, the LCO is another means to evaluate if any of the components of Fick's formula of gas exchange are impaired. Now, because in the interstitial type the diffusion is impaired, we will have decreased P to F ratio and we will have reduced DLCO. However, in non-interstitial type restrictive lung disease, such as chest wall disorder, myasthenia gravis, CNS depression, obesity, etc., DLCO is normal. If the LCO is normal, it means alveolo-arterial gradient is going to be normal. The cause of hypoxemia is impaired ventilation. In other words, we are mainly dealing with a hypercapnic respiratory disturbance. Give another example. Opioid use. Anything that impairs ventilation. These are conditions associated with normal AA gradient and both hypoxemic and possibly hypercapnic respiratory failure. Did I emphasize enough on this? If so, let's move to a very straightforward discussion focusing on differential diagnosis of hypercapnic respiratory failure. We have just one formula here, and that's the formula of alveolar ventilation. Before going to the differential diagnosis list, please analyze this formula. So if tidal volume is decreased, we will have decreased ventilation, and therefore we will have hypercapnia. If dead space is increased, this total value here would be decreased, and therefore we will have hypercapnia. If respiratory rate is decreased, as I just mentioned in opiate toxicity, we will have hypercapnia. One other additional fact to analyze this is what type of hypoxic respiratory failure usually accompanies hypercapnic failure. The answer is non-hypoxemic type, or the type with normal alveolo-arterial gradient. Okay, give example of conditions with increased dead space. Remember, we have two types of dead space. We have anatomic dead space, and then we have physiological or alveolar dead space. We already discussed the physiological alveolar dead space when we discussed pulmonary embolism, a condition also associated with VQ mismatch as the underlying cause of hypoxemic respiratory failure. Remember, if circulation, that is perfusion, approaches zero in the pulmonary circuit, the CO2 would remain in the blood. It will not be exchanged, and therefore we could have hypercapnia. Likewise, oxygenation would be impaired, and so we could have also hypoxemia. But most important example of increased anatomic dead space is seen in COPD. So if you are asked what type of respiratory failure is possible in COPD, remember that's mainly going to be hypercapnic. You remember why we avoid a target SpO2 more than 92% in COPD patients? Here is the answer. They are adapted with a CO2 retention, and their main respiratory drive under daily circumstances is a mild level of hypoxemia, and we should not eradicate that main respiratory drive for them. We will discuss PEEP as a very important scenario in which a patient may worsen under mechanical ventilation later on in the management of respiratory failure. Now, what are the differentials of conditions with decreased tidal volume as the underlying cause of hypercapnia? Well, we could have some alpha motor neuron or neuromuscular junction diseases such as spinal lesions, ALS, myasthenia, botulism. Also, don't forget the conditions associated with impaired chest wall mechanics such as obstructive sleep apnea, pneumothorax, rib fracture, and obesity hypoventilation syndrome. Now, if you are asked what ABG or VBG abnormality you could see in these patients with BMI more than 30, remember the answer is daytime hypercapnia. This can help differentiate them from obstructive sleep apnea patients, where we usually do not have anything in favor of daytime hypercapnia. Another final differential of low tidal volume is interstitial lung disease, in which all volumes are low, including tidal volume. Finally, we have differential diagnosis of conditions associated with decreased respiratory rate. Again, remember the normal range of adults is 12 to 16. We could have any CNS disorder, including encephalitis. We could have use of sedatives such as opioid use, or we could have myxedema coma in a severely hypothyroid patient. So, final case, if you are given a patient with slowed deep tendon reflexes, weight gain, dry skin, and low heart rate, who is being visited in the emergency room but gradually establishes altered mental status, and you are asked what should be the focus of treatment in case this patient needs mechanical ventilation. Remember, you need to focus on improving the ventilation, not oxygenation in this is because the patients with low respiratory rate have risk of hypercapnic respiratory failure. You need to focus on improving respiratory rate or tidal volume in your mechanical ventilation. Okay, this finishes our discussion of differential diagnosis in respiratory failure. This is one of the most challenging aspects also of the entire respiratory physiology, which is itself one of the most challenging components of entire human physiology. But this will facilitate our understanding of many concepts discussed on critical care as well.